and been taking care of kidney patients for about 28. So this is a topic that working in chronic kidney disease with ESRD component that we see a lot of in our practice and the patients that I manage. I'm excited that there are new novel approaches to managing hyperkalemia in our patients, as opposed to the old school ways of just giving certain medications, which were highly intolerable to most patients. So I'm excited to talk about this. So when we take a look at, sorry, I'm trying to go down. Sorry about that. Okay, so these are our learning objectives. And since this is getting continuing education, we will do a pre-test and a post-test. So I'll go through the pre-test pretty quickly, and then we will, of course, wrap it up at the post-test. So when you take a look at the first question, which one of, I'm sorry, I'm having trouble seeing this. I apologize. I can't see the top for some reason because it's not viewing my slide correctly. Let me just end this show real quick and look at it this way, because I'm having a little bit of trouble. So which of the following patients of your hospital med-surg unit would you be most likely to present with hyperkalemia? So as you can see, there's a poll right there, and so you can put your answers in there. Going on to the next question. I'm sorry, I'm having a lot of trouble here. The next question, and I promise to get to you to the bigger screen as we move along. The next question is our patient case, and it's JT. So JT is a 67-year-old male with chronic heart failure with reduced renal function. He recently admitted to the hospital from the emergency room. He presented with unexplained mild but persistent nausea and unusual muscle weakness. When his labs were drawn, it was found that he had a K of 5.7. There were no changes observed on his EKG. His current medications are the ACE and the ARB combination, which is taken twice a day, spironolactone once a day, and aspirin. So which of the following medications plans is most appropriate for this patient before his discharge? So one is to reduce spironolactone 25 once a day. One is to reduce it 25 once a day and discontinue it. The other one is to reduce spironolactone along with his ACE and ARB until potassium normalizes. And then the last one was obviously discontinue spironolactone, ACE and ARB, and have the patient return back in 2 weeks to get labs drawn. So moving to slide number 7, novel potassium binders such as SZC, which is local onset. It's approximately 1 hour. It's a leading interest in this agent for acute and hospital applications for treating hyperkalemia. Which of the following is true in a phase 2 Energize trial for the treatment? And as you can see, these are your choices. Going on to slide number 9, based on recent studies, which of the following are true regarding clinical utility of petromar in acute care settings? And since the poll is popping up on my screen, I'm just not gonna go over the answers the question choices. Moving on to slide number 10, a 59-year-old RJ was admitted to the ER with signs and symptoms of hyperkalemia. He does have a history of chronic kidney disease. His serum potassium level was 6.1. No EKG changes were observed. Which of the following is the most appropriate approach in managing his high potassium levels in the ER? Okay, and we're done with the pretest and we're going into the core of the presentation. So I think what's really important is for us to understand what hyperkalemia is. We use it pretty loosely. We talk about it with our patients, but it is most often categorized by the severity and classification as chronic. And especially in our ESRD patients, we see chronic hyperkalemia. We will start seeing chronic hyperkalemia also in late stage CKD stage 5 patients as they're coming close to kidney replacement therapy. Then, of course, there's acute, which is not known to be chronic. So if you take a look at your levels, when we take a look at when we see EKG changes with moderate 5 to 5.9, severe, we got moderate and severe when our K levels get to 6 or 6.4. Then, of course, we're going to see more severe changes when we have a hyperkalemia level of 6.5. So, what is the prevalence of hyperkalemia? So it really depends on, how we define it, the location, the comorbidity, and whether it's acute versus chronic. So in hospital settings, we see about 10% of hyperkalemia. We see a higher rate of hyperkalemia in heart failure patients. Of course, in our CKD patients, we see about 5 to 50%, depending on the stage. So again, looking at the later stages, stage 4, and of course, stage 5, we'll see more prevalence of hyperkalemia. And then we'll also see about 10% in RAS inhibition. So, how do we define signs and symptoms of hyperkalemia? So patients, most of the time, a lot of times, they are asymptomatic. Or they have these symptoms that we wouldn't even relate to hyperkalemia, such as fatigue or shortness of breath. Of course, we'll see some chest pain, but some people will have nausea, some vomiting, some diarrhea, played off as GI distress, and of course, muscle weakness. So usually EKGs will reflect some relevance to how high the potassium is. And as you can see on the right of the screen, we'll see these peaked T waves. The more, wide PRR intervals and the QRS duration along with the peak T waves. And then sometimes you see an absolute loss of P wave as well. So, but again, at times people will not have EKG changes with hyperkalemia. So who are at risk for hyperkalemia? And so when you take a look at, of course, our disease state, chronic kidney disease, but our diabetic patients and along with our heart failure patients. That's why it is always very challenging to manage chronic kidney disease patients who have these comorbid conditions. So when we take a look at, the progression of with hyperkalemia, what we take a look at here is, and as you can see at the bottom, we have these baseline serum potassium levels. And as you can see, that morbidity risk for hospitalization that will go up when we see increased potassium levels. So this was looking at a control group. We looked at diabetics, we looked at chronic kidney disease and heart failure. But when you combined all 3 of the comorbid conditions, which is heart failure, CKD, and diabetes, we can see definitely the probability of the mortality going up. And as you can see, the increase in potassium levels. So I think it's important for us to understand, what is the homeostasis and understanding potassium concentrations. I mean, when I talk with patients, I do a lot of CKD education prior to patients going on end-stage renal or kidney replacement therapy. I kind of talk about what's going on, how are we accumulating potassium. I think it's really an important concept for patients and providers to understand. So if you take a look at, our body, our intercellular storage of potassium is a total of 98%. So when you take a look at serum potassium levels, where do they come from? So we have dietary intake, of course, and then we also have intake when it comes to medications. So we're trying to manage these comorbid conditions. And so drugs can cause a shift from the extracellular to the intercellular space, such as beta-2 antagonists and insulin. Drugs that block the intercellular potassium uptake, such as digoxin or other beta blockers. And of course, drugs that block the aldosterone release or action. This is your RAS, your MRAs, and your heparin. So when we have, aldosterone stimulates K excretion. And so 90% of potassium is excreted in the kidney, while 10% is excreted from our colon. And so we always tend to think, when patients have diarrhea, this is what I always said, oh, they have diarrhea, that most likely their potassium levels are low. But surprisingly, I don't see that if I have a patient who's had an acute flare of diarrhea and had to miss some dialysis treatments, their potassium level, if anything, is stayed the same, if not a little bit higher. So, potassium is absorbed from the GI tract. And of course, it's filtered by the kidneys and then reabsorbed back into the blood. And so when you got chronic kidney disease and you're not excreting this, then your potassium is reabsorbed back into your blood. So the physiology of potassium removed during dialysis, during specifically hemodialysis. So I always talk to patients about how that dialyzer is the filter. Our kidneys are a filter. And when blood enters the kidney, it has poisons and toxins and high K levels. And once your kidney purifies or filters that blood, then you get rid of waste products through your kidney. And that's exactly how, as we well know, hemodialysis works. So we will see, though, interesting enough, when you have a patient whose potassium levels are staying high and you're worried about some recirculation of their access when they're on hemodialysis, I do see providers will draw a pre and a post potassium. And that's fine, because as you can see on the right-hand side of the screen, there is a change in potassium levels, blood potassium, serum potassium over time during and after dialysis. So you can see when a patient at the onset of hemodialysis, you are hyperkalemic or, a higher potassium level. However, once you're completed your hemodialysis session, your potassium level will decrease or normalize. However, you give that about 4 hours and you're going to start seeing a rebound in potassium levels. That's why we don't do a lot of post-potassiums. Very rarely do we do post-potassiums. I want to see what a potassium is about 4 hours after dialysis. However, the value of doing a post-potassium when you're trying to find recirculation of accesses is, well, if we see any decrease in the serum potassium level post-treatment. So when we take a look at causes of hyperkalemia, so you say to yourself, why is my patient hyperkalemic? Well, of course, dietary intake. So, I have a whole handout, a list of high potassium foods, low potassium foods. But again, when we looked at, the physiology and the homeostasis of potassium in 3 slides earlier than this, drugs can induce increased potassium or hyperkalemia. Potassium supplements, herbal supplements, when patients go in and get blood transfusions, or if they get lactated ringers during a surgery. I always, tell my surgeons, don't hang LR on my chronic kidney disease patients who are not on dialysis because of the risk of increased potassium levels. So you'll see altered K distribution when people are having metabolic disease, such as acidosis, or if they're having high sugars or hyperglycemia in our diabetic patients. Drug induced, so you have these insulin antagonists, these hypertonic solutions that are used, digoxin and beta blockers. And I know this is a little bit of a repeat from earlier. Reduction in K excretion. So why aren't we getting rid of potassium? Again, metabolic, and drug induced at the same time. We use potassium sparing diuretics. We use cyclosporin. We use tacrolimus, lithium in our patients as well. If we have impaired renin-aldosterone function, which we know is key to the homeostasis of potassium, we'll see, certain drugs used, such as ACEs and ARBs. These are your lisinoprils or anything with the prils. The ARBs are things like the sartans, like ibosartan, losartan, ARNNIs, MRAs, and these are your aldosterone receptor antagonists, such as spironolactone. And so you'll have, we did a large study at my institution looking at the increased potassium levels of spironolactone on our patients. Also, interesting enough, NSAIDs and COX-2 inhibitors. So if you have reduced glomerular filtration rate, eGFRs that are low, when our patients suffer from metabolic acidosis, so take a look at their CO2 levels. If they have heart failure, if they're dehydrated, when patients are dehydrated, we see spikes in creatinine levels, decreases in eGFR. Certain drugs, of course, antihypertensive, diuretics. And then, of course, there's always, if your blood is if there's hemolysis of your blood on blood draw, so which is also another case. So if you have patients who've been riding pretty normalized potassium levels, and all of a sudden you see a spike of about 7 point, a great spike, we always send them off for yet another stat lab. So when we take a look at rash use with hyperkalemia and the risk of that, it has to be a balance, correct? Because we know with RAS use, we understand that it is recommended for our patients. KDIGO recommends it. You'll see that the benefits of it are to reduce the morbidity and mortality in our heart failure patients. And again, those are very complex patients that we have to manage with chronic kidney disease. But RASs have great benefits. They reduce or slow the progression of chronic kidney disease in our patients, especially those with diabetic nephropathies. So we use a lot of it. And the problem is that when we can't use it is on the right-hand side, when we see high potassium levels because of it. And then we'll see spikes in EGFRs, decreases in EGFRs, spikes in creatinine levels, and with these patients because we've had to discontinue these medications. So, and this is just unfortunately causes adverse outcomes and increased mortality in our chronic kidney disease patients, as well as our diabetic and heart failure patients. So if you take a look at this slide, I know it's a bit of a busy slide, but, if we look at real world clinical practices and outcomes on, patients who have received RAS inhibitor prescriptions, this looked at patient records. So this was a medical record review of 205,108 patients, 1.7 million patient records. So if you take a look, again, a very busy slide, what you're seeing is that when you have changes to RAS therapy, it was discontinued because of tolerability in 14 to 16% of our patients. If you look at the bottom, it was discontinued after a hyperkalemic event in 22 to 27% of our patients, and it was down titrated. So we reduced the doses when we had hyperkalemic events at 16 to 21% of those patients. And so what is the effect of that, one would ask? So you get this cardiorenal adverse event or mortality occurred in 34.3% of patients who discontinued, and mortality was in 11% of those patients. So we understand the importance of using RAS. We just have to figure out how to manage the side effects of those medications. So when you look at hyperkalemia, there are clinical challenges. So especially in our patient population, it's very complex. So I always tell my patients, and my population is ever aging. I see more and more 80-year-olds, 85-year-olds who have chronic kidney disease, late 4, early 5s. And aging continues to reduce the EGFR and renin levels. We see patients with more comorbidities than I ever have out of my 28 years of managing kidney patients. And that puts them at really high risk of high potassium or hyperkalemia. These comorbidities, how do we treat them? They require RAS inhibitors, and that increases the risk of hyperkalemia. But as we saw on the slide before, that we saw 11% mortality in those patients who had to discontinue RAS therapy. So it puts patients at risk of events such as cardiovascular events, and of course, worsening of chronic kidney disease, which leads to ESRD and for patients. So comorbidities rarely are cured, if you think about it. I have patients who aren't cured with their diabetes, their hypertension, chronic kidney disease, and there's lifelong struggles with managing these diseases. I always tell my patient, I always can tell when patients' comorbid conditions aren't managed well, then their chronic kidney disease is not going to be managed well either. So education is powerful. So, if you say to yourself, what is our role in the management of hyperkalemia? So we have to assess what is hyperkalemia. I gave you a definition earlier. We talked about the homeostasis, how the mechanism of actions of how we have excretion and retention of potassium. But this requires, we have to understand all the mechanisms and evidence-based recommendations versus the risk and versus the benefits of using RAS inhibition in our patients who have heart failure, diabetes, and chronic kidney disease. So how can we play an integral role in this? So we need to do reconciliations of med checks, right? I always say it's too many cooks in the kitchen. So recognizing agents that may contribute to hyperkalemia on a patient's med list, or if you do simple brown bag medication checks where you're actually looking at bottles when patients bring them in, we can see discontinued medicine that our patients are still actively taking. Counseling patients on diet. you know what? I have become a dietitian. I swear. I know more ins and outs about how to manage potassium from a dietary standpoint than I ever thought I would know. But do they need to be referred to for a dietitian, and can get that be covered or reimbursed? But understanding, really talking with patients. I had a patient recently who was chronically in the sixes, who's ESRD, and I've tried everything to get it down. And I was simply just talking to her the other day, and for some reason we were talking about her bowels, and she goes, "Yeah, I eat 6 prunes a day." And sure enough, as much as I've gone over every food that I thought of that I could tell, I did not think she's eating 6 prunes a day. They're high in potassium. Sure enough, she stopped her prunes and her potassium went down to 4.7. So also educating our patients on the appropriate use of these things, what we're using nowadays called potassium binders. They're tricky. Patients need to understand how to take them, how to mix them, how to tolerate them, having any taste aversions. I had a patient who was on a potassium binder whose potassium was not coming down because he had problems with the taste, so he would mix it in orange juice. Well, obviously no one sat down and really told him, hey, orange juice has potassium, and we shouldn't be mixing your potassium binder in orange juice. But this is simple by just having conversation with patients. And I know we are busy. I know we're busy, we're short-staffed, but having conversation and listening to patients and letting them talk. I like them to do diet logs if possible. It's almost impossible to get them to bring it in, but just even, doing pictures of high potassium and low potassium foods, not just fruits, not just vegetables, but drinks and salt substitutes, different things like that. So when we manage hyperkalemia, we of course do dietary potassium counseling, and I tell them to try to avoid almost all salt substitutes unless they run it by me, because I really want to look. I also have a great handout for my patients on how to read labels. I think that's really important because patients, tend not to be able to read labels, but you got to remember the label reading is very small. So I have patients who can't see as well use magnifiers, or I just tell them to take a screenshot of it and shoot me a message in their electronic record or to my business cell phone so I can look it up myself. As we need to figure out how to manage RAS therapy. We need to reinitiate and titrate optimal doses after we get that potassium normalized. We need effective diuretic therapy in our chronic kidney disease patients, and especially our heart failure patients. The use of thiazide or loop diuretics with eGFRs at less than 30. I see that patients are, they're being managed on these medications. And also, we need to consider when to use a potassium binder. When do we intervene? So in our office with chronic kidney disease, we are checking potassiums, and we usually try to see our stage 4s for sure every 3 months. So we're checking potassium levels. Our stage 5s, I'm getting monthly labs as well. If we initiate any type of RAS therapy, I always check potassium levels as well. We monitor their comorbid conditions. We look at the medications that they take over the counter. We all know NSAIDs are bad for chronic kidney disease. We educate ourselves, our healthcare providers, our primary care doctors, our endocrinologist, our heart failure doctors, even to realize, yes, you have a heart failure patient, but your heart failure patient is also a chronic kidney disease patient. And we use a multidisciplinary approach. We have to work together hand in hand. And the one person I forgot to put in this multidisciplinary care was the patient, because it should definitely be the patient and their care partners. So when we talk about dietary potassium counseling, patients will say, well, how much potassium can I get in a day? So I usually tell them it's less than 2,400 milligrams of potassium in our patients that are stage 3B or higher with chronic kidney disease, especially if I'm using RAS therapy. Patients are at risk of hyperkalemia if they really need to receive dietary counseling. And I know it is very challenging to get dietary counseling. So again, I have a ton of handouts. I go over it at length with my patients. It's hard to implement, adherence with this. Patients love to eat tomatoes in August. Patients love, certain cultures love this. Other patients, don't want to give up this. And we also need to restrict the consumption of certain healthy foods, such as the DASH diet. That is very challenging. So this is just a list of foods that are high in potassium and greater than 20 milligrams of potassium per portion. So I have lots of handouts I give, but I put the portions on them. I just don't say, don't eat a tomato. Or if you're going to eat a tomato, eat one slice of it. This is very, very fruitful, helpful if patients know what is my portion size. So it's really important. So I'm not going to go over all of this, but again, one thing that we tend to forget about is truly salt substitutes and salt-free. Patients just don't realize that they're salt substitutes. They're trying to do well. They're trying to control their blood pressure. They're trying to get low salt in less than 2,000 milligrams of salt in a day. And then sure enough, they're throwing potassium all over their food. So when you take a look at adjusted survival probabilities associated with changes in potassium levels, potassium levels fluctuate. If you're trending potassiums, you're just kind of in a quandary sometimes understanding why it's up, why it's down. We always have to recheck potassiums if we feel that there's something awry here. Readings can be very different between them coming to your outpatient clinic versus going to the ER versus being hospitalized. So this is a single study in patients with heart failure checking potassiums at discharge, routine clinic visits, when they're hospitalized, and they found that potassium's normalization from hypo to hyperkalemia was independent associated with lower risk and mortality. So long-term monitoring and control can definitely help reduce mortality from running hyperkalemic. So again, looking back at the nursing considerations for this. So potassium is a common ingredient in many foods. So again, going through the diet, looking at adherence issues, and encouraging everyone get involved. Who is buying the patient's food? Who is cooking for the patient? So many people to talk to when it comes to potassium and diet. It's also, there's variability among patients. Patients will have the same degree of residual kidney function on the same diet, but some might get hyperkalemic and others may not. So don't assume. There's many factors that play into this, but diet is just one of them. But being consistent and following up and sending the message over and over. When I sit with my chronic kidney disease patients, I go over their labs. When I do kidney disease education for patients, I go over their labs. I talk about it. I trend their labs as well. I find it very beneficial when we look at trends in labs for our chronic kidney disease patients. So when you take a look at the management based on potassium levels, so there's NICE, and this was a study you're looking at not starting RAS inhibitors if your potassium level is greater than 5. And then with heart failure patients, you should be using it with caution if patients have greater than 5 potassium levels. And then using ACCs, AHHs, and HFSAs, we use this in caution again if starting a RAS if patients have a greater than 5 potassium level, and we do not start the aldosterone receptor antagonist, the MRAs. So we can reduce if you noticed that you're using MRAs and your potassium levels in your heart failure patients are going up, we can reduce that MRA dose by 50%. But when we see potassium levels get greater than 6, then we stop, and we carefully really reintroduce them. So when you take a look at the outpatient management, so when you do dose changes of your RAS therapy, it requires new prescriptions. That's something, it's a no-brainer. And then new potassium, these new novel potassium binders may require prior authorizations. So don't just assume that you're going to write a prescription for a new potassium binder for a patient and expect it to get covered. Very rarely do I find that this happens in our chronic kidney disease patients. In our ESRD patients, I even have trouble with it as well. So there is paperwork to be filled out. What do? We monitor potassiums. We take a look at blood pressures. We take a look at the creatinine levels. We want to know what their kidney function is. And of course, you want to evaluate what is their volume status. Are they volume overloaded? Are they dehydrated? And what is their adherence with their diet? Having real conversation about diet. So when you take a look at these novel potassium binders, the first one is the sodium polystyrene sulfonate, SPS is what I'll refer to it as. And then we look at petrilamur, which is the sodium zirconium, SZC. So you guys, when we take a look at, the SPS has been around for a very, very long time. It was actually approved before the era of evidence-based medicine. That's how long Kxalate has been around. We don't know exactly the onset of it. It's presumed that it happens in 7 to 10 hours. Time to become normalized potassium levels is very undetermined. And there's some pretty darn serious risk effect, adverse events, drug events with using it. However, when we take a look at the two new potassium binders out there, they've been approved in our patients with CKD, with heart failure, with diabetes, and who are on RAS inhibition therapy. We know their onset is within hours. We see a reduction of 0.7 to 1.1 milliequivalents within 48 hours. Studies have shown long-term use demonstrates safety and efficacy at 52 weeks. And we have seen that the rebound hyperkalemia doesn't exist with these patients. It's stopped. It's lessened. So it's very important. So again, looking at old school ways of treating hyperkalemia to the two new novel potassium binders that are out there. So when we take a look at the potassium, the petrilamur, looking at it, how does it work? So its primary effect is in the colon. It's a potassium binder in exchange for calcium. So the onset of action is usually about 7 hours. It is available in powder packets. These powder packets need to be refrigerated. They're stable for 3 months at room temperature, though. So I do tell patients that. The starting dose should be 8.4 grams once a day, and then we titrate that weekly. Some of the adverse events is constipation, low magnesium levels, and then diarrhea. So I do talk about it with my patients. And another situation I have is just some taste aversion issues with the potassium binder. So it is a powder for suspension. So it needs to be mixed in water, juices that are not high potassium juices, or soft foods such as puddings or applesauce. And you need to separate how it's given by certain medications by 3 hours to avoid certain drug interactions. And it can be taken with or without food. I usually have a lot of my patients put it in water. They put it in, they mix it up, they drink it really fast, and then they chase it with something else. And it's usually pretty darn tolerable. Mm-hmm. So, I'm sorry, and let me go back up here. Okay. So the next potassium binder that we're going to be talking about, traps potassium in throughout the intestine. It is an exchange of sodium, hydrogen for potassium. The onset is much quicker, 1 hour. The starting dose is usually 10 grams 3 times a day for up to 48 hours. You usually have a maintenance dose about 5 grams every other day to 15 grams per day, depending. Again, this is all individualized prescribing. The daily dose is anywhere between 5 and 15. This is once daily on non-dialysis days. We titrate that up weekly. We draw potassium levels. We monitor. The adverse drug events with the medication is you'll see maybe some dose dependent edema, about 4 to 16%, and some low potassiums. So again, this is a powder. It needs for suspension. You mix it with water. You have to separate the administration of this with certain medications by 2 hours. And again, it can be taken with or without food. So again, it's kind of tricky. I tell my patients, we play around with it. We see how it'll be better adhered to with any taste issues or suspension issues, different things like that. So when you take a look at the studies, though, we have the harmonized study, and then you have the petrilamur study. When the first study included 258 patients, and as you can see, the potassium declined in these patients from 5.6 to baseline of 4.5. And if you take a look at the patient population in this out of 258, 66% of those patients were chronic kidney disease, 36% of those patients had heart failure, 66% of those patients were diabetic, and 70% of those patients on RAS. So when you take a look at petrelintide, we see 25 patients, 100% of them had chronic kidney disease. 28% of those patients had heart failure, 60% diabetics. The potassium declined from 5.9 down to baseline to 5.1 in 48 hours. So we have some good options out there. So they did extension studies on this, and it included 746 patients. And this was during months 3 to 12. 88% of patients had a serum value of potassium of 5.1. As you can see, they were initially hyperkalemic at 5.6. And as you can see, within 24 to 72 hours, they went down in about 4.8, and then they stabilized out, which is the numbers we want to see. We want stabilization of potassium levels. And as you can see on the right-hand side, they had 304 patients in this study with type 2 diabetes receiving RAS therapy, plus or minus CKD or heart failure patients. The target range for the potassium was 3.8 to 5, and it was maintained through week 52 in up to 92% of their patients with mild hyperkalemia, and 77 to 95% with mild hyperkalemia. So you can see we have two very effective potassium binders out there. So there was another study called the Dialyze study, and this looked at patients, 196 of them, who were dialysis dependent, so ESKD patients. And we were in this study, it was looking at pre-dialysis potassium levels. For about 41% of the patients maintained the pre-dialysis potassium level between 4 and 5 and did not require urgent rescue therapy while on the medication. So they initially were screened, they were put on a dose, and then they were evaluated, as you can see down here. And so, again, pretty effective. So taking a look at how does potassium binders work well in our heart failure patients. Again, it's really, I have about maybe 20% of my patients are heart failure patients who are also chronic kidney disease. And our heart failure patients end up in the hospital frequently. And because of volume issues and shortness of breath, overall decreased quality of life, just trouble maintaining themselves at home. So if you take a look at what we use in our patients with heart failure, spironolactone is wildly used, very common. And so if you take a look at the Pearl HF study, it included 155 patients who had chronic heart failure, and their eGFR was less than 60. They already had a history of hyperkalemia, resulting in the discontinuation of RAS. So 91 of these patients were able to up-titrate the spironolactone once they added the potassium binder, compared to 74%. If you look at the Diamond study, that included 878 patients with heart failure and a history of high potassiums. These patients, once they were treated, had fewer patient events with potassium levels greater than 5.5 and an MR reduction. 85% of these patients optimized the dose of RAS with the use of potassium binders. And that's what we want to see. We want to be able to manage their heart failure, control their potassium as well. So when you take a look at the summary here of chronic hyperkalemia summary, so we see that we have these potassium binders that are studied in our patients with chronic hyperkalemia. They are looked at in patients who have high risk factors for hyperkalemia. And these are our patients, the heart failure, the diabetics, the CKDers, the RAS usage for these patients. We have found that they're very effective in treating hyperkalemia in an outpatient setting, in the ambulatory setting. The last thing you want to do is send patients to the hospital, right? ED because of high potassiums. Overall, they're very well tolerated. I do have patients who have GI problems with both of the potassium binders. I tell them it might take a week, maybe a week and a half to get through it. But once you get through it, then they're usually fine. So I'm just very upfront and honest with patients. Again, having conversation with patients. These potassium binders have shown that there's safety and efficacy data for up to 1 year. The drug-drug interaction issues are manageable. Low potassium is very uncommon. The rebound hyperkalemia is not seen. But how about the patients who have, or we see acute hyperkalemia with in our patients? So when you take a look at this case study, number one, this is a 65-year-old female who is a diabetic nephropathy, hypertensive, presents to the ER after receiving a call from her primary care provider stating her potassium was elevated after starting an ACE inhibitor. So when you take a look at her medication list, she's on metformin 1,000 milligrams twice a day. There should be a lot of dings going on here. Lisinopril 20, amlodipine 5 once a day. Effervescent 10 milligrams daily, along with an aspirin. Her potassium levels revealed that she was at a K level of 5.8 and a creatinine of 1.7. So when you take a look at, when we take a look at which of the drugs would be best to manage in our patients in the ER, and that is a question. Do you treat them with furosemide? Do you treat them with this patient with a potassium binder? Do you treat this patient with bicarbonate or calcium gluconate? So when we move on further, we talk about what are the best ways to manage acute hyperkalemia to answer that question. So the goal is basically to prevent or minimize any electrophysiology effects on the heart to reduce the immediate risk of arrhythmias. So we want to make sure that we can get a membrane stabilizer with calcium, potassium shifters they use in the ER, insulin and glucose, beta-2 antagonists, sodium bicarbonate, and of course, waste. How do we get rid of potassium? Of course, with our diuretics, our potassium binders, and of course, acute hemodialysis. So when you take a look at, it's highly variable in the ER. When we look at real world studies, observational studies of 14 ERs to determine what ER does what and why. So some ERs do monotherapy. Some ERs will do 2 therapies. Some will do 3, some will do 4, and some will do 5. This was looked at 203 patients with potassium levels greater than 5.5. The authors found no standard universally accepted treatment protocol. And this is very complex and diverse practice patterns were observed. So again, I think it's based on the experience level of the emergency rooms. I also think it's based on, medication availability in these ERs, what's on their formulary. Do they even have hemodialysis if, potentially needed, and how well versed they are in managing our diabetics, our CKD, our heart failure, and our ESRD patients with hyperkalemia. So what are the challenges, of managing, hyperkalemia with dialysis? So treatment is not physiological. So if you think about what happens on hemodialysis, there's major and rapid fluctuation in potassium levels that can occur during in-center hemo treatments and home hemo treatments. So you have to be very mindful of what potassium baths you're using with your patients. It's almost non-existent to see any patients on 1K potassium baths, in the outpatient setting. We have found that patients have had too drastic of rapid fluctuations in potassium levels on 1 potassium bath. So also other conditions can be combined with this hyperkalemia that can be exacerbated, such as left ventricular hypertrophy, hypomagnesemia, low calcium levels, and then they can become alkalotic as well. So how do we prescribe? It's not always, how do you monitor potassium levels in your ESRD patients on in-center hemo or more frequent hemodialysis? So it's protocol to check your potassiums once a month. Our protocol reads that if our potassium levels are elevated, I will always, reassess the patient, talk with the patient. The dietitian will talk with the patient. We will see if there's any dietary changes, medication changes, something that happened that we were not aware of, and then we repeat it. But what's really interesting is that potassium levels can change day to day. I could draw, and so you're drawing potassiums. Normally we draw our labs on Monday, Tuesdays. I always want to see what potassium levels are after a 2-day skip. I think it's real world data. So I can talk with patients. Hey, you know what? You can't be eating all this potassium foods on Saturday and Sundays and coming here on Mondays with really high potassiums. We do lots of education on that. It also gives you an opportunity to talk with patients when they miss their dialysis treatments, and you can talk about the risk of high potassium levels. I actually, when my patients miss dialysis and they do, we usually check potassium levels when they come to dialysis, even if it's after 1, 2, or even 3 missed dialysis. And I really show that to patients, like, look, at this was to happen. You're not getting rid of potassium except for when you come to dialysis, because you're not making any more urine. I do have patients with residual renal function, so they're treated obviously differently. But again, you're looking at the patient. So so how do you use these novel potassium binders in your ESRD population, right? And for potassium use in the ER. So there was 2 studies. One was called the Energize study, and the one was called the Reduce study. So the Energize study included 70 patients with a potassium level of 5.8 or greater, and they were randomized to the potassium binder along with insulin/glucose or a placebo of insulin and glucose. So the authors found a similar reduction 1 hour, suggesting that the potassium lower effect background insulin glucose is dominant. So in the Reduce study, that showed 30 patients with potassium levels greater than 60 and compared 25.2 grams of patolimar dose for their standard of care. And they found a reduction within 2 hours and no difference at 6 hours. So we got KDIGO. This is where we live. This is where we live and breathe. And the recommendations on how to manage acute hyperkalemia in the ER, and looking at the use of potassium binders. And I know this algorithm is kind of lengthy, but if you take a look at this is one protocol or algorithm that an ER would use based on EKG changes, yes or no, when to give calcium levels, when to give IV insulin or glucose, when to consider bicarbonate if they're acidotic, when to consider a diuretic like furosemide unless your patient is anuric or severely volume depleted, and then considering potassium binders. So it kind of shows that the potassium binders are a little bit late in the game. This is another very involved management of hyperkalemia. This is an algorithm. It's a very tasteful algorithm that was just published in 2021, but it is really good as an algorithm for EDs to manage hyperkalemia in our patients. And I won't go through all of this, but again, you can see a lot of it is based on, with EKG changes, needing emergent dialysis, what to do when their potassium level is 6 or greater, less than 6, when to consider bicarbonate. But we're finding is we're not wanting to use K-Exolate anymore. We're wanting to use the other 2 novel potassium binders instead, because of the efficacy, because of the safety, because we know the onset of action with these medications. Seeing very little K-Exolate use in the emergency rooms nowadays. So, but again, some emergency rooms, that's all they have. So if we look at the second case study, I've got about 10 minutes here. We have a 72-year-old male with heart failure with an EF of 25%. He has advanced cardiovascular disease. He's stage 3 CKD, has depression, develops hyperkalemia during a hospitalization because his heart failure, he had decompensation of his heart failure. He's currently again on ACEs and ARBs, as you can see, twice a day. Spironolactone, which is very appropriate for heart failure patients. Metoprolol, beta blocker. Think about those drugs we talked about earlier. Zoloft for depression, and on furosemide, which is a diuretic. So lab results reveal K of 5.4, creatinine of 1.5, and a pro BNP of 3,500. So what is the best way to manage his acute hyperkalemia in an outpatient setting? So some of the options could be prescribing loop diuretics, prescribing a potassium binder, change a diet order to lower potassium, or again, yet another potassium binder. So when we take a look at managing in acute settings, we have a cohort of patients of 881 encounters of these patients who use patolimar for hyperkalemia in acute settings. And these patients included heart failure patients. And as you can see, the serum baseline potassium changes in these patients. Their mean potassium had a reduction of 0.5 at 5 hours, and with a mean lab draw of 2.9 hours. So there was no need for additional potassium binders needed in 82% of these patients. So if you take a look at yet another study for the treatment of hyperkalemia, again, This was a retrospective study looking at 138 patients whose potassium were between 5 and 5.9, comparing them to a single dose of SPS versus no treatment during their hospitalization. When it was given SPS, it reduced the potassium by 0.4 more than the control. So the clinical relevance was unclear. However, toxicity profile suggested that routine use in mildly hyperkalemic patients was not warranted. So we saw no difference in the reduction, as you can see here. So when we take a look at the case study 2, this was that 72-year-old patient, and his current medications again, and the repeat lab on the day of discharge. If we get down to the bottom paragraph, the potassium was 5.0 after one dose of the potamer, which is the potassium binder, and the episode of hyperkalemia prior to admission was documented in the EHR. So it did show that when you gave the potassium binder, we did have reduction in the potassium. So what were the recommendations for the appropriate management of his chronic hyperkalemia due to rash use? So should you discontinue the ACE/ARB? Should you discontinue the spironolactone? Should we discontinue the potassium binder, or should we discontinue, the Kayexalate? So if you take a look at, when you take a look at serum potassium levels, when you consider using a potassium binder, so think about this. If you have a potassium binder and the potassium levels between 5 and 5.5 on follow-up, should the RAS dose compromise is a concern, or do you maintain it? And usually what we'll do is maintain it. We'll reassess the potassium level after 1 week. If high, add the potassium binder, adopt MAR dose if necessary. So we might have to change the dose of the spironolactone. But generally, we do not reduce the ACE and the ARB and the ARNIs, which, because we want to preserve, renal function. We want to, demonstrate that we can manage their chronic kidney disease, their heart failure, their diabetes. You can continue once potassium levels if they are persistent and greater than 6, we always reassess potassium levels after 1 week. If high, we add the potassium binder. We have to reduce the MRA dose, and we do reduce the ACE inhibitor dose. Again, this is a reassessment. So once we add the potassium binder, if we then see that we can maintain potassium levels again between 5.1 and 5.5, then we reconsider our medication management. So what we have found our patients, these guidelines for patients with heart failure, we found that our potassium binders have been shown to lower potassium levels and enable treatment with RAS in patients with heart failure who experience hyperkalemia, which is defined by 5.5 or greater. So what we see is improved clinical outcomes. And it's still a little bit uncertain and under investigation, but from our standpoint and our practice point standpoint is we have seen better clinical outcomes in these patients if we can maintain them on the RAS therapy. So when you take a look again at assessment management for inpatients, we want to look at their I's and O's, right? We want to look at their intake. We want to look at their output. We want to actually get real weights on patients daily, accurate weights. We want to monitor for any adverse drug reactions. We want to follow up with a post-discharge appointment. We want to make sure patients are aware what their discharge medications are. And of course, understanding why they take these medications is so vital. So if we take a look at a summary on how to manage acute hyperkalemia in our patients, as you saw in that study, there were no clear recommendations if ERs do monotherapy, 2 drugs, 3 drugs, 4 drugs. It is all over the board. And this is for emergency rooms, this is for inpatient, and this is for traditional care management. There's a lot of variability amongst practices on how they manage their patients with hyperkalemia, especially with the comorbid conditions of diabetes, heart failure, and chronic kidney disease. Novel potassium binders are not approved for life-threatening hyperkalemia. So we have this emerging role of seeing these potassium binders as monotherapy and or adjunct therapy for the acute care setting. However, again, more studies are warranted to look at safety, efficacy, and maintenance of these medications. So just some key take-home points for this is that managing high potassium levels in the acute and the chronic setting is very complex. It requires a lot of thinking, a lot of putting things together, going over a multidisciplinary approach with diet, medication management, working with specialists, especially their endocrinologists, their heart failure doctors, CKD doctors, all of us communicating. Who's the cook in the kitchen? Who's going to lead, be the lead here? What I recommend to my patients, and I might be a little bit conceited or advocate too much for our roles as nephrology providers, is as I usually tell my patients, if you have any outside specialist, especially in my fours and my late fours and my fives, CKD patients, I really say, if any doctor wants to prescribe you anything, first of all, let them know you have chronic kidney disease. And second, call our office just to make sure that, we're all on the same page with medication management. It has to be communications between when they're in-house, in the hospital, and upon discharge. It's very confusing. They might get a discharge summary of all these medications. They might not pick them up, and then they start taking their old medications. Team members need to talk. And of course, conversation between nursing staff and patients. Education by far is the key. It's powerful. It empowers patients and it empowers us to know more how to manage our patients. So having your patient know what a low potassium diet is, having the patients read labels, understand portions. What portion of this is going to give me this much potassium? Understanding that there are novel potassium binders out there, that they're accessible. Yes, you might have to jump through hoops with prior authorizations, but once you get them approved, they're very, very effective, and they can manage our patients and slowing the progression of chronic kidney disease down. They are, when patients are adherent with them, it's, we don't see the rebound hyperkalemia that we have seen in the past with the KX-Lite, of course. So getting back to the post-test. So that's the end of the presentation. So again, these are your post-test questions. I have about 2 minutes. I'm not going to go through these since we went through these at the beginning. And you guys recorded your answers. So
sorry, I at least have to ask them. Sorry, I'm going to just pop them up on the screen real quick.
Oh, so you're going to have me go through the answers?
Well, yes, and
Okay.
announce their correct answer. I'm sorry, we have to do this for the outcomes.
Okay.